Effects of stabilization exercise of upper extremity on reduction in pain of patient upper extremity and functional improvement. Introduction. The shoulder joint is one of a few joints connected to muscles and tendons in a human body. Although muscle and tendons enable the movement of arms in a wide range, only one-third of the humeral head is in contact with the glenoid fossa in the scapula, which means that the shoulder joint is a joint that is very weak in terms of stability. Because of this, the shoulder joint is the most commonly dislocated joint in the human body. Dislocated may also incur hand injuries. Primarily, the connective tissues such as the joint capsule, ligament, and glenoid labrum align and protect the joint for bone. Secondary, muscle tone and contraction protect the joint, thereby preventing dislocation or subluxation. Stroke patients are generally divided into spastic and flaccid patients. Spastic patients have an imbalance between the agonist and the antagonist muscle group in a joint, while flaccid patients do not have muscle assistance when their bones are maintained by joint due to weakening muscle strength. For stroke patients, the dislocation of the shoulder joint occurs frequently. To prevent this, many patients wear a bobbas sling that has a pad under the armpit. The dislocation and subluxation of the shoulder joint leave a significant impediment on motor and sensory abilities in the elbow, wrist, and finger as they press the brachial plexus that passed under the armpit. Thus, the prevention of dislocation is an essential part of the functional rehabilitation of the upper extremity for stroke patients. Many shoulder joint dislocations are anterior shoulder dislocation. Anterior shoulder dislocation occur due to direct external injuries or during fall on a outstretched hand. The injury type is divided into Bankart region and Hill-Sachs region. Uh, Bankart region is detachment of the glenoid labrum or the articular capsule from the anterior glenoid cavity, which can be seen by arthroscopy or magnetic resonance imaging. Hill-Sachs region is an injury in the articular cartilage or an osteochondral injury, which can occur due to the collision of the posterolateral side of the humeral head with the glenoid fossa. A Hill-Sachs region is a bone injury that can be seen by general imaging method. To treat patients with anterior shoulder dislocation, surgical, non-surgical, and conservative treatment can be applied. Among them, patients who choose surgical treatment had a lower recurrence rate than patients who choose other treatment. For stroke patients, shoulder pain and subluxation are the most common complications and can induce functional disabilities. Its incidence rate is 55% on average. Shoulder disabilities of Stroke patients are closely related to the degradation in their quality of life and are one of the factors that contribute to long hospitalization. And in addition, this can be a factor that has a negative impact on early rehabilitation of stroke patients, which can adversely affect the patient's prognosis. Thus, the stability of the shoulder is initially supported through a sling or elastic bandage to prevent the dislocation and stabilization of the shoulder of stroke patient. However, the long-term sling attachment may be a limitation for patients trying to strengthen their muscle. Accordingly, the use of sling should be minimized, and stabilization training should be conducted to initiate the rehabilitation of stroke patients for faster rehabilitation of paralyzed muscle early in their stroke. The arm of stroke patients are constantly pulled in the lateral inferior direction due to the effects of gravity. For stroke patients with shoulder muscle paralyzed, only the tension in the ligament capsule and glenoid labrum support the arm weight. Thus, subluxation could occur without external shock, and the dislocation and subluxation can easily occur with a very small shock. As a result, muscles should ensure the stability of the shoulder through stabilization exercise for shoulder joints to relieve the shoulder pain of stroke patient and accelerated rehabilitation through the increase in functional activities. Stabilization exercise for shoulder joints is an exercise without too much pressure on the shoulder joint, which can be relatively safely applied to patients immediately after shoulder joint surgery. The stabilization exercise of shoulder joint is used to correct functional impairment such as the abnormal location of the scapula and abnormal movements to provide overall stability throughout the shoulder corridor. The Swiss ball is a widely used tool in the core stability exercise. Marshall reported that the stabilization exercise using the Swiss ball had a significant impact on the activation of the rectus abdominis. They also proved that the activation of the trapezius was higher when the wall-press exercise using the Swiss ball was conducted. It has also been reported that closed-chain exercises are functionally more advantageous for proprioception stimulation than open-chain exercise. The stability of the scapulothoracic joint is more important than the glenohumeral joint in the shoulder joint. The scapulothoracic joint is not a true joint, but it plays an essential role in the mobility and stability of the shoulder joint. Thus, the stability in the scapulothoracic joint was attempted first by applying the shoulder joint stabilization exercise for patients with dislocation of the shoulder joint. The muscular atrophy and shortness in surrounding the shoulder joint, such as the teres minor, teres major, subscapularis, and rhomboid, serratus anterior muscle, and the lower trapezius can be prevented, and the muscle strength can be strengthened through the stabilization exercise. Previous study has been conducted on the comparison of recurrence rates between non-surgical and surgical treatment. Few studies have been conducted of pain control during range of motion and functional assessment of the shoulder joint after the surgery of patients with shoulder dislocation. This study aimed to determine the effect of the shoulder joint stabilization exercise on the pain and function of patients with shoulder dislocation after surgery. Method. The subject. This study selected 30 patients after releasing the fixation who were no more than 3 months after their shoulder surgery. The subject had physiotherapy for 30 minutes, and the control group, uh, 15, had traditional physiotherapy for 30 minutes, while the experimental group, 15, has shoulder joint stabilization study for 30 minutes, 3 times a week for 6 weeks. The researchers evaluate the brain functions and the joint range of motion of the subject. The treatment was conducted by two experienced physiotherapists with more than 10 years of clinical experience. Intervention procedure. More specifically, both the experimenter and control group had hypertonia for 20 minutes, following by transcutaneous electrical nerve stimulation for 10 minutes and laser treatment for 10 minutes. Then each group had their group intervention for 30 minutes. For the intervention in each group, the experimenter and the control group conducted short stabilization and general exercise respectively. Pain and functional test. To assess the pain level of the subject before and after the treatment, 100 millimeter visual analog scale (VAS) was used in which patients expressed their pain level in the shoulder joint by seeing the VAS to assess the function of the shoulder joint. The Constant-Murley scale (CMS), which is known as a standardized clinical measurement method, was employed. The assessment item pain level, joint range of motion, activities of daily living, and muscle strength of the shoulder joint. The total score was 100 points, which were divided into 35 points of subject element and 65 points of objective element. The subjective elements were pain level, 15 points, activities of daily living, 20 points, and the objective element were range of motion, flexion, abduction, external rotation, and internal rotation, whose possible total score was 40 points, and shoulder joint muscle strength, 25 points. The higher the item of total score is, the better the shoulder function was. To measure a range of motion, goniometer was used to measure the passive and active flexion and extension in shoulder joints. Intervention method. For 15 subjects of the control group, 20 minutes of hypertonia, 15 minutes of transcutaneous electrical nerve system stimulation, and 10 minutes of laser were applied as a general physiotherapy treatment to control the pain. And then 20 minutes of interferential current therapy and 5 minutes of ultrasound were applied. For 15 subjects of the experimental group, the same general physiotherapy treatment applied following by stabilization exercise. The shoulder joint stabilization exercise were conducted on a patient who lied flat on their back on the treatment table, and the patient's joint was located with the Swiss ball while flexing the knee joint at 90 degrees. Both feet were conducted at the bottom of the treatment table. The Swiss ball was fixed through adduction and retraction of the shoulder joint by the patient. Patients with low back pain or abdominal support to relieve their pressure on their waist. In addition, the patient had their elbow joint flexed at 90 degrees while standing and fixed the Swiss ball against the wall in the treatment room using the wrist of their lower arm and leaning forward. Here, the therapist instructs the patient to push their arm outward to maintain the position. All exercise has patients maintain their posture for 10 seconds, followed by 5 seconds of rest. This was done 10 times to complete one set. For the scapula stabilization exercise and the shoulder joint stabilization exercise, 3 sets were conducted and 3 minutes of rest were given between sets. For the stabilization of the scapula and the shoulder joint, the therapist let the patient apply the resistance against various directions. The treatment was conducted 3 times a week for 6 weeks for a total of 18 exercises. Data analysis. For the data processing in this study, descriptive statistics were conducted to determine the general characteristic of the subject. A field sample t-test was conducted to determine the difference in functional improvement before and after the treatment of the experimenter and control group. An independent t-test was conducted to determine the treatment effects between the groups. Result. There were 30 subjects participating in this study. General characteristic. In below table, you can check them. The result of the experimental group before and after the treatment exhibit that the joint range of motion in active flexion, active abduction, and passive flexion, and the VAS results were statistically and significant different, and all items in the CMS was statistically and significantly different. Result of the control group before and after the treatment exhibit that the joint of motion in active abduction and the VAS result were statistically and significantly different, and only the total score in the CMS was statistically and significantly different. Difference before and after treatment between the experimenter and control group were statistically significant in the joint range of motion in active abduction and simple shoulder test, and only the power item in the CMS was statistically and significantly different. Discussion. The shoulder joint is a joint that is highly mobile but low in stability, which is used most frequently in the human body. Around 95% of the patients who experience dislocation for the first time due to external force, such as external injury or a fall. The dislocation is likely to occur again if it is not properly treated early in the dislocation. The recurrence occur more often in their journeys with a probability of up to 95%. The functional impediment or pain in the shoulder has a significant impact on daily activities and cause a serious problem that degrade one's quality of life. Tony studies recurrence rate of patients with shoulder dislocation. They found the 9 out of 12 patients who had non-surgical treatment, 75%, and 1 out of 9 patients who had arthroscopy surgery, 11.1%, showed the recurrence. However, patients who had surgical treatment had difficulties in daily living activities due to the limitation in their joint range of motion after surgery. Thus, their physiotherapy should focus on the recovery of the joint range of motion without pain and the prevention or recurrence of shoulder instability by strengthening muscle strength. As found in the report by Botany, the recurrence rate of patients after surgery was not 0%. Thus, post-operative management is important. The treatment approach for the shoulder does not separate each of the joints one by one. The movement of the shoulder is completed by the movement of the scapulothoracic joint, glenohumeral joint, acromioclavicular joint, and sternoclavicular joint. Since the shoulder joint is extremely mobile and unstable in the human body, instability can be raised through muscle. This stabilization is ability to finally control the joint consciously or unconsciously, and stability of the scapula affects normal movements of the shoulder joint. The scapula is the bone where many muscles are attached to increase the stability of the shoulder joint. Thus, the stability of the scapulothoracic joint should be established first. Then, the glenohumeral joint should stabilize the shoulder joint, although this is not a shoulder joint. The stabilization of the scapula primarily provides stability throughout the shoulder girdle and is also used to correct abnormal movement. The treatment of external rotation of the glenohumeral joint should also be taken in parallel, since both the abduction and the flexion movement of the shoulder require external rotation. Pain will occur easily without the correct execution of external rotation movement. Thus, after obtaining the stability of the shoulder girdle, an approach should be taken in the following order: external rotation, flexion, abduction, adduction, extension, and internal rotation in the glenohumeral joint. The CMS results in this study are similar to those in the study by Saw and Shin. However, the simple shoulder test results in the present study were not statistically significant in the experimental group, which was in contrast with those of Saw. This result was due to the difference in patient group. The VAS result in the experimental and the control group in this study were similar to the group in the studies conducted by Sa and Shin. The experimental group in this study had statistically significant results in the active flexion, active abduction, passive flexion, and the VAS and each item of and the total score of the CMS. These results are similar to those of Park and Jung. The control group in this study had statistically significant difference in active abduction, SST, a simple shoulder test, and the power item in the CMS before and after the treatment. The stabilization exercise had a positive impact on power, functional recovery, and pain control. When comparing the difference before and after the treatment in the experimental and control group, the joint range of motion, activities of daily living, passive abduction, and total score of the CMS did not show significant values, but the exercise using the Swiss ball had an effect to some extent, considering the change. This study had limitation in that its experiment period was short and only the pure stabilization exercise was applied and compared within patients who had their shoulder joint capsule repair. For, for future studies, the stabilization exercise will be conducted for patients with stroke and who have joint capsule repair. The stabilization exercise will be applied while aligning their bodies or conducting the passive movement in parallel, which will be more systematic and efficient than the current study. The future study will also see which muscle are activated during the exercise using electro and myography. Thank you.